The following is a video on arthroscopic resection of a displaced lesser trochanteric fragment, namely efficient access and instrumentation following prior revision hip arthroplasty. The following are our disclosures. In terms of patient presentation and pertinent anatomy, this thin patient sustained a periprosthetic fracture of the lesser trochanter following revision total hip arthroplasty. The migrated fragment is visible on her anteroposterior and lateral radiographs and was palpable through the anterior groin soft tissues and causing mechanical symptoms and irritation. These symptoms were made transiently but substantially better by ultrasound-guided corticosteroid injections over the fragment. On computed tomography imaging, the fragment, marked with an asterisk here, was anterior to the capsule and notably approximately 16 millimeters from the neurovascular bundle. Understanding anterior hip anatomy is critical to safe arthroscopic access and fragment removal. Namely, the iliopsoas, highlighted here, is located immediately deep and lateral to the femoral nerve, artery, and vein. In this three-dimensional model, one can appreciate the relationship between the anteromedial border of the iliopsoas, shown by the green dotted line, and the femoral neurovascular bundle, shown in red. Specifically, as one moves proximally in the direction of the fragment migration, the two structures come in increasing proximity. The patient is positioned supine on a hip distraction table with the feet placed into padded boots. The operative extremity is placed in 10 degrees of external rotation to anteriorize the iliopsoas bursa. No distraction is applied. The patient is then prepared and draped in standard fashion for hip arthroscopy. The femoral artery is palpated and marked. We mark the anterior superior iliac spine and draw a safety line to the lateral border of the patella. The anterior and posterior borders of the greater trochanter are marked, as is its proximal extent. It is worth highlighting here that in thin patients, the working zone between the trochanter and line of safety may be as small as 2 centimeters in width. We are now ready for arthroscopic access. Employing a Wissinger rod in fluoroscopy, we mark the level of the vastus ridge, the lesser trochanteric fragment, and the anatomically intact location of the lesser trochanter. A 17-gauge access needle is employed to access the iliopsoas bursa, abutting the posterior and lateral aspect of the fragment, as this is furthest from the neurovascular bundle. The inner stylet of the needle is removed, and a syringe is employed to perform an air bursogram, which confirms satisfactory location and demonstrates mobility of the fragment and its medial displacement in the bursa. A small incision is made over the wire, and a 5 mm inner diameter palmar cannula is placed over the nitinol wire. We advance an arthroscopic trocar to abut the fragment under fluoroscopic visualization. The wire is removed and a 70-degree arthroscope inserted into the cannula. Water inflow is immediately begun at 35 mm mercury. A second mid-anterior portal is established approximately 1 centimeter medial and 3 centimeters distal to the anterolateral portal. A needle is triangulated to the tip of the arthroscope, then a nitinol wire introduced, then an incision made, and a 5 mm cannula introduced over the wire to dilate a tract for subsequent instrumentation. The cannula is removed, and a 4.2 mm straight shaver is placed percutaneously into the developed potential space. We are now ready to clear bursal tissue and identify the lesser trochanteric fragment in the scarred iliopsoas bursa. The fragment can be localized both with palpation of the arthroscopic shaver as well as with fluoroscopic confirmation. We then percutaneously exchange our shaver for a radiofrequency ablator and use this to begin to clear scar tissue and iliopsoas tendon from the migrated fragment. We are now ready to begin fragment mobilization. Our goal is near circumferential dissection about the fragment, including proximally, medially, and distally, as confirmed by fluoroscopy, understanding that the generated potential space often migrates the fragment medially with fluid distension. A technical pearl is to employ the arthroscope as a retractor. Here we show the ablator first pushing the fragment down and the arthroscope then retracting in this direction to provide additional proximal access. Here we show a similar maneuver employing the arthroscope to lift the fragment and thus employ our ablator distally and posteriorly. Once satisfactory mobilization is obtained, an alligator hook tip grasper is employed through the mid-anterior portal to gain control of the fragment and subsequently remove it in its entirety. Fluoroscopy is employed to confirm the absence of any residual osseous fragments. External examination demonstrates a fragment anatomically comprising the lesser trochanter with an outer shell of cortical bone and inner shell of trabecular bone. Incisions are closed with 3/0 monocrol followed by 3/0 nylon sutures in horizontal mattress fashion. A sterile dressing is applied. Patients are allowed to wait as tolerated immediately postoperatively, often using crutches for 2 to 3 days until their pain, strength, and gait improve. On behalf of Mayo Clinic Orthopedics, we thank you for your time and attention.